Thank you very much. Can you hear me, yeah? Yeah. Okay, great. So hello, everyone. Good afternoon. It's been a long day, so hopefully I won't keep you for too long. A little bit about me. This is me. Every talk I give, I start with my identities. And I do so because I believe that my identities are completely interwoven in who I am, how you see me, how the world sees me, and how I lead and serve in all I do. So this is me. I'm a black female. I'm a surgeon. Training as a black female in Ireland, bringing its own challenges, as you can imagine, in education, as you've already heard, but also a mother, kind of bringing that idea of patience and resilience and a lot of empathy. So for me, this is all of my identities kind of woven together as in all I do and how I portray myself. So my talk today is going to kind of bring in all of those aspects today in what I speak about. So we've kind of just looked at some of those affiliations that that has been mentioned, and I just list them here. But also note that I have no conflict to declare today. Before I start, it would be amiss of me not to mention EACH. So EACH is the International Association for Communication in Healthcare. It's an international global organization that kind of brings healthcare professionals together, researchers, educators, policymakers all together. As you can see, EACH was started in 2001, and we have grown in strength every single year. EACH works across three broad areas. There's a research arm of it, there's a teaching arm of it, and there's policy and practice committee. We also have special interest groups, as you can note there, and also early career committee within EACH as well. So it's a really, really great organization, and one that I'll definitely encourage you to consider joining, because it really does bring to life everything that we've been talking about today at this symposium, and EACH obviously supporting this symposium. So what do? We promote teaching across the board from globally, but also the research and teaching aspect of it, but also policymakers. So if you go on our website, there's definitely a call for membership, so please do check it out. So EACH, if you put it in and put communication after it, it should pop up at the top of the list on Google. So definitely encouraging you to join EACH. So today I'm just going to give you a little taster of my research. So as Jeremy mentioned, I did my PhD on gender and looking at surgeons and the challenges that surgeons face in the workplace. I'll talk a little bit about communication and empathy. You're all experts in it, so I'm not going to labor too much on it. And some of the strategies that we have engaged in to actually bring this forward across the board. I want to start with stereotypes. I think you probably look at the picture there and you kind of go, oh yeah, that would be a typical surgeon. That's what my vision of a surgeon is. And I think this, stereotypes is one of the key things that I'll be speaking about, because I think that is what has led to that talk, that surgeons lack empathy, because of the stereotypes that we put on them, and as Jeremy already mentioned. I have a quick video to play, and then we'll go straight into this. Now, hoping it plays for me.
Ortho, you can come in. It's okay, you can come in. I've got weights, kettlebells. I've even got a yoga mat over here. Oh, okay, no yoga? Come on in, have a seat. What up, feelings, bro? You know you don't have to be nervous. I just get anxious around medicine doctors. Look, no stethoscope. I'm not going to hand you an EKG. EKG? Electrocardiogram. Danger squiggles. Oh, good. Ortho, you haven't seemed like yourself lately. What's going on? Nothing's going on. I'm fine. You barely want to do any burpees anymore during our sessions. It's the internal medicine doctors. They keep making fun of me. And how does that make you feel? Like I have a lot of bicep strength, but not a lot of brain strength. Ortho, who knows more about bones than anybody else? Nobody. I know the most. Who can replace any joint in the human body? Me. Who named their first child femur and their second child, who they don't like quite as much, fibula? I did. And what do these other doctors know about bones? Nothing. That's right. Bro, they still use the term compound fracture. They don't know what they're talking about. It's open or comminuted or both. Okay, yeah. They're ordering non-weight-bearing knee x-rays. Nobody knows bones like you. I'm just as smart as they are. Yes, you are. I'm probably smarter. Oh, I mean, I can manage diabetes. No, I don't think you need to. I can do anything. Thanks, feelings, bro.
So typical stereotypes that we associate with surgeons, yeah, we could do anything, including manage diabetes. Not too sure about that. But anyway, so I think when we look at surgical specialty, these are kind of common things that come. And interestingly, in some of the research that we did, even young kids kind of have that perception, because stereotypes is something that is inbred at the very, very beginning of life. The girls wear pink, boys wear blue, and suddenly society has already created that stereotype across the board. So when you look at surgical specialties, the masculine domain, the hierarchy culture that exists there, the tradition of old boys club, spending too much time, long time in training, and then obviously the high pressure of where it works. And I suppose in reality, a lot of surgeons demonstrate this empathy. However, under a lot of circumstances, challenging circumstances, but more importantly, I think sometimes it's really not seen. I think a lot of people really don't value what the empathy is. So my talk over the next while is really just to kind of look at some of the research that we've done across surgical specialty, to kind of look at what the surgical cultures is all about, to look at the intersecting identities that I started off with, and some of the career transitions that we have in surgery. And these are based on the 3 papers that we've published out of this research. So let's start off with gender-based stereotypes. So gender-based stereotypes are things that we see all the time, especially in surgery. We talk about motherhood and competence. This is very, very common in surgery, where a lot of female surgeons will return after maternity leave. You've spent a year out on maternity leave. The first day you come back, you're straight into the operation theatre, trying to struggle, trying to do what you need to do to catch up and work. Reintegration into surgical practice, a challenge. Is that the fault of the female surgeon or the fault of the system? What exactly is the challenge there? We look at motherhood penalties. You come back and your child is sick, you need to go off and pick up the child or whatever, but you're penalized for doing that. You're penalized for looking after the child. We look at part-time trainees, and this is for male and females. Part-time training started in Ireland in 2013. Prior to that, there was nothing like part-time training, less than full-time training, flexible training. Why is that? Because it was seen that people have to work full-time. If you want to be a surgeon, you have to work full-time to be able to get to that training. There's loads of gender expectations within surgery. Those gender expectations lead to, women, if you display empathy, or you're a little bit too soft, or it's not being valued. Or on the other hand, if a male displays empathy, no, can't be displaying empathy. Because those are the stereotypes that we see and we put on surgery. So empathy really is a double-edged sword. When you display it, you're judged. When you don't display it, you're judged. And the question of that is, why is that? What is the challenge there? Is it the individual or is it the system? We'll look at ethnicity-based stereotypes. A lot of challenges in some parts of the world. So intersectionality is one that was described by Kimberly Crenshaw, where she talks about that different identities we have actually make up who we are and how we actually portray the world. So when we actually look at ethnicity-based stereotypes within surgery, there's significant challenges around, is it the ethnicity of the person? Does that make them a good surgeon? Or is it the system? There's overlapping identities really impacting on and shaping who the surgeon is. There's different cultures that display empathy differently to other cultures. And there's biases that we have, significant biases that marginalize groups, leading to the challenges of emotional burden. So when you have emotional burden, how are you impacting empathy and the challenges around that? In surgery, we look at age-based stereotypes. So age-based stereotypes exist across the board in all of the cultures that we looked at, where young female are often questioned about their ability and their experience. Young female surgeons would go to the wards and they're mistaken for another healthcare professional because they're not seen as female as surgeons. Young male surgeons also have challenges because they kind of say, oh, you're still young, you're not quite there yet. Whereas older male surgeons are great. They have the competence, they've been really good, they have the experience. And yet, we have that stereotype. Oh, they're a fantastic surgeon, but it's okay, the bedside manner is not great, but that's okay. So we accept that, and society kind of prominates that going forward. And we have professional identity stereotypes, leadership roles, and the conflict with leadership roles. Leadership roles, okay, maybe not so much as a female surgeon. Would you take on a leadership role? You've got family commitment, probably not, because you have a conflict. Female surgeons as carers, what are the challenges around that? Or well, if you're caring, you're comforting, you're nice, and it's completely gendered. So there's emotional labor around that. So when you display your empathy, or you're a bit too soft. And then the mentorship gap that we see across the board, where surgeons are looking to see, I need to see someone like me that can actually do this. How do I actually break that barrier and break those challenges? So these are some of the stereotypes that exist within surgery that leads to the challenge and propagating lack of empathy within surgery. So we look at surgical cultures. And this is another impact, this is another aspect that impacts on surgical cultures. When we look at surgical cultures, we use the Hofstede's cultural dimension to actually look at this. One of the lenses, this is a lens by Gert Hofstede, who actually created this, the psychologist, who looked at cultures, not just organizational cultures, workplace cultures, but also national cultures, and looked at the 6 dimensions of culture. The 6 dimensions being power distance, individualism versus collectivism, masculinity versus femininity, uncertainty avoidance, long versus short-term orientation, and indulgence versus restraint. This was used to define the different aspects of a culture. We used this in our study to actually look at, within the surgical culture, how does this actually portray across the organization or within surgical cultures. Over the next 6 slides, I'm going to portray quotes, illustrative quotes from our study, looking how the system, surgical cultures within the system, propagate lack of empathy. So starting with masculinity. Some of the traits that we saw with masculinity include competition, achievement, heroism, and assertiveness. And this creates a culture where empathy is completely undervalued. Collegiality is seen as a weakness. So if you're trying to be a surgeon and you're within this culture, how do you progress and how do you demonstrate empathy? This quote is a really good quote from a male consultant surgeon who showed that during their training, it was a really nasty atmosphere. Everybody was competing because they had so many slots, consultant posts at the end of training. So everybody was competing, making it a nasty atmosphere. So really focusing on the individual achievement over collective support and that emotional detachment and lack of support, so that people weren't even focusing on other people's struggle, really just focusing on their own. Power distance was the next dimension we looked at. And power distance is around hierarchy and unequal power distribution. This is where senior surgeons often go unchallenged, and I'm sure you've heard of stories around that in each of your practices, even when there's inappropriate behavior, and this has been published widely. This is one of the quotes that actually shocked me, and I think the sad thing is that the individual has actually left surgery as a result of the impact of this. So she had an appendectomy, and even though she was on the pill, she got pregnant. There was a board meeting to decide whether she will continue with her surgical training or not, leading to a conversation that they will allow her to continue her training if she resigned, and if she didn't, she will not be signed off for her fellowship exam. How can one individual have such an influence on people and yet with no consequences? So hierarchical situations or hierarchical structures within organizations discourage people from speaking up, and hence is normalizing disrespect and abuse. Individualism versus collectivism. Prioritizing personal goals versus group loyalty. This is where individuals from a collectivist society felt isolated and disrespected within our system, especially with male colleagues from similar backgrounds. An interesting one, this female surgeon talks about her challenge from people of her own background not respecting her because she was a woman. They would isolate her, and they probably hated her, she said, because she felt she was a strong, independent, westernized woman. The lack of empathy there just really shows the cultural clashes. Even though they were from the same culture, but because she was a female, there was a lack of inclusive practices and alienating her, and obviously leading to that emotional harm. Uncertainty avoidance was another dimension within Hofstede. And this is a preference for stability or resistance to change. So this is where you have your traditional status quo of the old boys club. So this Scottish female trainee talks about how her consultant would invite people to his house, but turn around to her in the midst of everybody and say, obviously not you, and walk out. Once again, not challenged. So exclusionary practices reinforces that gender bias and prevents emotional connection or support. How can you demonstrate empathy in such a situation? Long-term orientation is around perseverance and delayed gratification. Training structures that demand very long hours, and traditionally surgery has always been very long hours. But that's fine. However, is the lack of support from the system that is a challenge. So this patient, who's also a medic, talks about the challenges of the low representation in some of the specialties, but also how the long hours is really not conducive to family life, really ignoring those personal circumstances. And finally, the last dimension is indulgence versus restraint. That's suppression of enjoyment. In this quote, this female consultant talks about doing her written paper 10 days before having her baby, and then the oral exam straight afterwards, where she had to study for quite a while. But she was commuting 90 kilometers every day to work. She said to her husband, I need 6 weeks where you can forget about me, so she could study for her exams. She'll come back by 6, study till 1 a.m., and then get up and work the next day and study for 12 hours during the weekend. So the culture that glorifies sacrifice without acknowledging the emotional toil is also challenging. And how can you demonstrate empathy in this? So these are the 6 dimensions of Hofstede, really showing the challenges that the system has created and the stereotypes that it's created, leading to the lack of empathy. When we look at surgeons, the individuals involved in each of these scenarios and each of the discussions, we know that the empathy is not deficient. It is there, but the system is hiding it. So it's a hidden strength within each of that. So we know that surgeons themselves are deeply empathic. Male surgeons show empathy, and when they do, they are deeply respected and people appreciate it. Patients appreciate it. So it's not fully absent in surgery. It's just under-recognized, undervalued, and misinterpreted as weakness. But also the system propagates this, and the system becomes a significant challenge. We know that when we looked at our patient narratives, patients described their surgeons as empathic, highlighting the importance of interpersonal skill. This Irish patient talked about how her surgeon was extremely competent, but not only that, demonstrated empathy and called out the empathy and how it made her feel. The second patient talked about her technical skills as well as her interpersonal skills. So we do know that it is valued, and we do know that our surgeons do have it. The question is, how do we change the system to support them in that process? In addition to that, the colleagues also like the empathy when it's demonstrated to them. So this is an Irish nurse who said she's worked with consultants, male, who are very empathic, who would always give them a title as an honorary female. And that's back again to the stereotype, where we've gendered everything in surgery. So that gendered stereotype associating empathy with femininity. So as a surgeon, that's one of your challenges. So the reality about surgeons is that many surgeons display deep empathy and compassion, but the problem is the challenging circumstances, the stereotypes that we've put into it, and the systemic issues that we have in surgery. So my title should really be it's not the surgeons, it's the system, and how do we actually manage that? So when we look at the evidence, they're all experts in this room, so I'm not going to focus on that. We've already spoken in all the workshops today and all the discussions. We do know that empathy improves patient outcomes, absolutely does. And we do know from a surgical session that it does the same too. We do know that it's measurable, absolutely. There's surgical education programs that do measure, and there's targeted therapies. And we do know that statistics shows that the studies and emphasis of essential role emotional intelligence in surgical practice. So I'm going to just give you a sense of what we've done within our university and in some of the areas that we've worked, of how we've actually integrated this based on the learnings and the lessons we've learned. The Royal College of Surgeons, obviously we are since 1784 focused on training surgeons, and then since after that had an undergraduate medical education. So for us, this is a really key aspect that we ensure that we make sure that we bring this forward. So we know empathy is a skill, can be taught. We've all been talking about it today. I've just attended a workshop where there was lovely role play, storytelling and ways to actually deliver that. We know that there's definitely challenges in high pressure environments like surgery, but yet it's still possible to train it. And how do we do that within the constraints of what we have? And fostering empathy improves patient outcome, emotional resilience, and so on. So I want to come back to TEACH, which was started in 2008 and focuses specifically on teaching communication skills. And if you attended the masterclass earlier, you'd see a taster of how it actually works. One of the things that TEACH does is really focuses on when do we teach. So it's not just about the teaching, but also kind of bringing out how do we actually integrate this into our curriculum. So there is a course that we run on curriculum development, which would definitely encourage you to attend if you're trying to build this within your programs. And it talks about when we teach we teach students without training. We know students' communication skills totally deteriorate. We know that without reinforcement, learning from one course to the other deteriorates over time. And we know that it has to be integrated in a longitudinal program. So based on that, principles that TEACH focuses on is that communication skills and their importance should be introduced very early in training. It has to be just-in-time training and learning, and it has to be helical rather than a linear curriculum, and integrated, not separated, and a tick box. So our CSI in our medical school, this is what we've taken on board, and this is how we have integrated a teaching of empathy within our curriculum. So we've recently had the opportunity to revamp our curriculum, and we have called it a Transforming Healthcare Program. we use the 3 apprentices of learning, knowledge, skills, personal and professional identity. For the very first time, all 3 of these pillars are of equal importance. For years, knowledge was always the main focus, that we need to make sure you have the right knowledge, and then a bit of skills, make sure you have the skills, and the personal and professional identity was kind of seen as a side. We have now launched this as a 3 main pillar of the curriculum, which means that you could have all the knowledge and skills but fail on the PPID. So that's really a key aspect of our curriculum and something that we've integrated and we assess across the board. Our clinical skills has become a vertical theme within the curriculum, and we have identified 5 pillars under the clinical skills: communication, physical examination, prescribing, procedural skills, and team around the critical thinking and working within team. And all of those completely encompassed by a professional, entrustable professional activities. To deliver that, we focus and we prepare students right from day 1 of medical school across the 5 years of the curriculum. Some of the things that we focused on is the whole idea of positive education, and that has become a key strength of our curriculum, really underpinning all aspects of our curriculum across the board. To initiate this within the curriculum, we needed to make sure that it was a whole institution approach, that there was organizational culture that actually supports that, and that staff were trained and prepared for this. But more importantly, that there is an assessment pillar attached to this, because if it wasn't assessed, it wouldn't be taken seriously. We've introduced the growth mindset within our curriculum, and obviously with this growth mindset kind of brings in the whole idea of empathy leading to more constructive feedback. It's really the philosophy that is underpinning all of our curriculum. And really enhancing that growth mindset really strengthens the relationship between empathy and growth mindset, really kind of bringing that forward within the discussions that the students have in their classrooms. We've captured this in personal tutor meetings where academics meet with students and they demonstrate that empathy on a continuous basis. One of the things that we've done in our curriculum, 2 weeks into medical school, we have introduced stories in the form of case-based learning, where students start to understand the other person's perspective, but not on the perspective from the foundational sciences point of view, but the foundational sciences is completely interwoven into this, but the whole curriculum is now based on stories about the patient, and really kind of taking that journey, that perspective taken on the other person, on what's happening with the story, with the patient. So this is the very first case that our students encounter, is of Kate, who's an 18-year-old, so very similar age to them, and Kate is having challenges around her health. And it introduces Kate's life, all the people that are involved in Kate's life, what she's doing. Kate has just started university, how she's engaging in university, her home, and how she's engaging with her doctors. Within this, we start to teach students the other perspective. What are the challenges that you're seeing? We start to introduce team-based empathy. How does that work? Working in groups, the students work in groups of 12 to actually deliver this. What is the other person's perspective? Really starting to bring that to life with the students. And that has worked extremely well. And we're now seeing students becoming more resilient, more empathic in their interactions with each other. So some of the other principles that TEACH obviously looks at is the principles of clinician behavior change. And with that is really looking at some of the content of the core which can be applied. How do we actually deliver that teaching to ensure that we do have that behavioral change? And do we do that by choosing the particular teaching types that we do? So we need to know in communication training, need to know what you're looking for in an effective communication in order to be able to analyze it. So some of the teaching methodologies is what we've applied here, and some of those is what you would have seen in the classes later on. We also have in our CSI a postgraduate surgical training. Postgraduate surgical training is obviously our CSI, is what we really focus on, and that is a key aspect of our institution. In our postgraduate surgical training, we're very proud to have the Human Factors in Patient Safety Program, the first of its kind worldwide, really training surgeons across the board from the first year of their training all the way through. And in that is really focusing on the communication skills, and empathy is threaded through all of that program. We also have a diploma and a master's in human factors and patient safety, really trying to bring home to our surgical trainees the key across communication. We know that delivering this program over the last while, there's been significant improvement in communication skills over the last 2 years of that human factors training. And this is shown by the graph here and the paper that is published here by Eva Doherty and her group, who's sitting in the crowd. So, looking at some of the strategies that we need to kind of bring forward, I started off by kind of giving you the stereotype that we have in surgery that has created this belief that surgeons lack empathy. Then kind of moving on to the surgical culture, which we do know is toxic, and we are working to kind of manage and fix. And then moving on to some of the teaching that we do in our undergraduate and postgraduate training. I think it's really important that we reframe the narrative. We need to change the issues that we have in surgery. Empathy is a vital leadership skill, not just for non-surgeons, but for everyone, including surgeons. And it does enhance surgical practice and patient outcomes, that is without doubt, and the literature is there to show it. We need to reframe the narrative of that traditional detached surgeon, because it is harmful and it is causing harm across for our junior students and junior doctors coming on board. We need to emphasize the fact that there has to be the new type of surgeon that is coming. Earlier on, we talked about AI. So the world is changing. We do need to change that narrative. We do need to also reframe the narrative about, fostering compassion, emotional resilience, and better patient care, because that cultural shift is required for us to actually move forward. And there has to be a systemic change around achieving the new narratives required to redefine professional norms in surgery. How do we progress forward? We need to integrate empathy into medical education from a very, very early age to help future surgeons create that compassionate care. And that has to be integrated at the very start of medical school. Mentorship, I think, is really key, and role models are really key. And there are people in surgery that do demonstrate and do exemplify that empathy, and it's really important that we do emphasize that and we do bring that forward. There has to be institutional support to be able to do this, and I do think that institutions need to recognize the need for emotional resilience and empathy through supportive policies. So it's not just doing it, but we need to have policies to support it and back it up. And leadership and policies change are essential to foster that cultural change. So it's not just the individuals. I think the culture needs to change. We could train the individuals, but the culture within our system does need to change. So to kind of finish up, empathy is essential in surgery. We know that. Surgeons definitely have empathy. There's challenging stereotypes and embracing diversity will definitely help redefine what it means to be a modern surgeon. And I do emphasize that modern surgeon, because it's not just the traditional old boys club has to go. And encouraging questions and collaboration advances empathy and healthcare quality. Empathy is not a luxury in surgery, it's a necessity. And it's a necessity to ensure that we have better patient outcomes and better patient care. I'd like to finish up by highlighting 2 conferences that are coming up, and this is the EACH conferences. So EACH is, once again, International Association for Communication in Healthcare, where this is fully embedded. ICCH 2025 is happening with our sister organization, ACH, the Academy of Communication and Healthcare, and that's on the 5th to the 8th of October. It's happening in Ottawa. If any of you are around there, definitely do drop in. And ICCH 2026 will happen in this side of the world. So every second year is in Europe, and the alternate year is in the North America. So this 2026 will be in Europe. We haven't quite announced the venue yet. It's usually a secret until you get to the ACH 2025 and it's announced, apart from last year where the secret spilled out. But it's on the 14th to the 18th of September 2026. So we definitely encourage you all to please do attend. But, and remember to join each as a member. So I'll finish on that within time. Yeah, thank you very much.